Basics of Medical Biochemistry. First edition, 2024. Chapter 21. Vitamins, Part 4 of 4. By Professor Dr. Muhammad Jawad. MBBS, Dao, M. Philosophy, Ph.D., Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau Medical College, Air University-PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. 21.14 Folic acid. Folic acid is one of the members of the vitamin B complex. It is a slightly water-soluble hematopoietic vitamin also known as pteroyl-glutamic acid, PGA, tetrahydrofolate, THF, vitamin B9, or vitamin M. Chemically, folic acid is made up of pyridine base attached to p-aminobenzoic acid and glutamate. When exposed to light, it is rapidly destroyed. Figure 21.18 Structure of folic acid, vitamin B9. Sources of folic acid. Folates are synthesized in bacteria and higher plants. Animals cannot make p-aminobenzoic acid or attach glutamic acid to p-aminobenzoic acid, and all the required folic acid is ultimately derived from microbial and plant sources. The main sources of folic acid are green leafy vegetables, liver, nuts and whole grain cereals. It obtained its name owing to richly found in the foliage of plants. Folates present in natural food sources are quite unstable compounds. A significant loss in vitamin activity occurred during food processing. In vegetables, up to 40% of folates can be destroyed by cooking, and in cereals, this loss is up to 70% by milling and baking. Absorption, transport, storage, and excretion of folic acid. The dietary folic acid mainly exists as polyglutamate with 3 to 7 glutamate residues which cannot be absorbed in the intestine. The glutamate side chains are cleaved by the enzyme folate conjugase or polyglutamate hydrolase to monoglutamate. The enzyme folate conjugase is present in the duodenum and jejunum. Only the monoglutamal form of folic acid is absorbed from the intestine. After being taken up by the mucosal cell, monoglutamate is reduced to tetrahydrofolate and then methylated to form N5-methyl tetrahydrofolate, which enters the portal vein and is transported to the liver. N5-methyl tetrahydrofolate is the major form of folic acid in the blood, loosely bound to plasma proteins, especially albumin. Within the liver, tetrahydrofolate is reconjugated to the polyglutamate form to be further used in various reactions. Folic acid is mainly stored as polyglutamate, with 5 to 6 amino acid residues, in the liver in the amounts of about 10 to 20 mg. Folic acid carrying polyglutamic acid cannot be transported back out of the cell. Folic acid is excreted in bile, but most are reabsorbed. Recommended dietary allowance, RDA, an adequate intake daily, aid *, of folic acid. Infants, 65-80 g. Children, 150 to 200 g. Men and women, 300 to 400 g. Pregnancy, 600 g. Lactation, 500 g. A moderately high intake of folic acid is not toxic but might mask an underlying vitamin B12 deficiency that only becomes apparent once the irreversible neurological disorders set in. Large doses of folic acid, greater than 1000 g/day, can antagonize anticonvulsants which could cause problems for epileptic people.
Activation of folic acid. Folic acid is not the active form of the vitamin. It needs to be reduced to tetrahydrofolate, THF. Dihydrofolate reductase found in some microorganisms, example the malarial parasite, is quite different from the human form and can be inhibited with drugs, example trimethoprim, that have little effect on us. This enzyme is also targeted by anti-cancer drugs.
Figure 21.19 Activation of folic acid, vitamin B9, just the business part of the folic acid is shown for ease of illustration.
Functions of folic acid. It acts as a coenzyme in many reactions involving the transfer of one carbon atom to other compounds. The single carbon groups can be carried on N5, N10, or bridged between both these nitrogens of THF. THF acts as an acceptor or donor of 1 carbon units, formyl, methyl, etc., in reactions involving amino acid and nucleotide metabolism. Generation of 1 carbon units. Many compounds, particularly amino acids, act as donors of 1 carbon units. For example, formate is released from glycine and tryptophan metabolism combines with THF to form N10 formyl THF. Histidine contributes formamino fragments to produce N5 formamino THF, and serine is converted to glycine during the formation of N5 N10 methylene THF. This provides a most common route of 1 carbon units entry to 1 carbon pool. Main forms of 1 carbon units include methyl, CH3, formyl, CHO, methanil, equals CH, methylene, CH2, hydroxymethyl, CH2O, and formamino, CH equals NH. THF exists in many forms with 1 carbon groups such as N5-methyl THF, N5N10 methylene THF, N5N10 methanil THF, N5-formyl THF, N10-formyl THF, and N5-formamino THF. N5-methyl THF is the main form of folic acid found in plasma. Different forms of THF provided with 1 carbon unit are interconvertible and thus metabolically significant for maintaining the steadiness of 1 carbon pool.
Figure 21.20 Attachment of various 1 carbon groups to the tetrahydrofolate, THF. Significance of 1 carbon unit. They are utilized for the synthesis of a large number of compounds such as purines, glycine, formyl methionine at the initiation of protein synthesis, pyrimidine nucleotide, etc. N5-methyl tetrahydrofolate in relation to vitamin B12. The reaction between N5-methyl tetrahydrofolate and homocysteine is catalyzed by the enzyme methionine synthase in the presence of vitamin B12 as a coenzyme to produce tetrahydrofolate and methionine. N5-methyl tetrahydrofolate plus homocysteine tetrahydrofolate plus methionine. This is the only reaction regenerating tetrahydrofolate from N5-methyl tetrahydrofolate. Without it, all the tetrahydrofolate will eventually end up trapped as N5-methyl tetrahydrofolate. Methionine is an active donor of methyl groups in transmethylation reactions. Methionine is converted to homocysteine after the release of the methyl group. For the regeneration of methionine, homocysteine and N5-methyl THF are required to react together, which is vitamin B12 dependent.
Synthesis of deoxythymidylate, DTMP. N5N10 methylene tetrahydrofolate transfers a methyl group to deoxyuridylate, DUMP, to form DTMP, essential for DNA synthesis. This is important in cells that are dividing rapidly, such as red blood cell producing bone marrow cells, hair follicles, intestinal mucosa cells and cancer cells. Rapidly dividing cells need to replicate their DNA often. Methotrexate, an analog of folic acid, binds to folate reductase 1000 times more tightly than folate. This inhibits the conversion of folate and dihydrofolate into active tetrahydrofolate. Methotrexate is used to treat leukemia. It works by inhibiting the production of tetrahydrofolate, which in turn limits the amount of N5N10 methylene tetrahydrofolate available for DTMP synthesis. Figure 21.21 Synthesis of deoxythymidylate, DTMP, ser, serine, GLY, glycine.
Folic acid antagonists, aminopterine and amethopterine, methotrexate, are structural analogues of folic acid. They competitively inhibit the enzyme dihydrofolate reductase in humans. This inhibition impairs the formation of the active form of tetrahydrofolate from dihydrofolate. During the conversion of deoxyuridylate to deoxythymidylate, dihydrofolate is formed and utilizes N5N10 methylene THF. Deoxythymidylate is required for DNA synthesis. Folic acid antagonists block DNA synthesis and inhibit cell division. Sulfanilamide is one of the first antibacterial drugs. It is structurally similar to p-aminobenzoic acid and inhibits the enzyme, dihydroaptate synthetase, responsible for incorporating p-aminobenzoic acid into folic acid. Since this incorporation does not occur in animals, the drug selectively inhibits bacterial metabolism by inhibiting their ability to make folic acid. During treatment, we continue to obtain folic acid for our own needs through our diet. Trimethoprim is another folic acid antagonist. It inhibits bacterial dihydrofolate reductase. It impairs the deoxythymidylate synthesis, leading to decreased synthesis of DNA. It is mainly used to treat bacterial infections.
Figure 21.22 Structure of sulfanilamide, left, and p-aminobenzoic acid, right.
Clinical aspect: aminopterine and amethopterine, methotrexate, inhibit DNA synthesis in cancer cells, thus used in the treatment of cancer, particularly leukemia and choriocarcinoma. Sulfanilamide and trimethoprim are used as effective antimicrobial agents. Deficiency of folic acid. The deficiency of folic acid is induced by conditions with increased demand such as pregnancy and lactation. It also occurs in poor absorption, as in treatment with folate inhibitor drugs, pathology of the intestine, sprue, celiac diseases, gluten-induced enteropathy, resection of jejunum and short-circuiting of jejunum in gastroileostomy, alcoholism, etc. Sulfamethoxazole interferes with folic acid absorption, and methotrexate affects the production of THF. Loss of folic acid is also seen in patients on dialysis. Folate-free diet can cause deficiency within a few weeks.
Megaloblastic anemia and folic acid deficiency. Folic acid deficiency reduces the capacity of the body to make DTMP, which affects the rapidly dividing bone marrow cells associated with red blood cell production. Megaloblastic changes are seen in the bone marrow and mucosa. There is hyperchromic macrocytic anemia due to maturation blocked. Patients look pale with glossitis, diarrhea, depression, and confusion. There is azoospermia in males and amenorrhea in females. In infants and children, folate deficiency can cause growth retardation. Folate trap. Pernicious anemia due to primary deficiency of vitamin B12 giving secondary deficiency of folic acid because all the folate ends up trapped as N5-methyltetrahydrofolate. Laboratory findings in folic acid deficiency. The peripheral blood smear shows macrocytic hyperchromic anemia. Hypersegmented neutrophils. Bone marrow examination shows megaloblastic changes characterized by large-sized erythroid cells with cytoplasmic maturation and impaired nuclear maturation due to defective DNA synthesis. Decreased plasma folic acid levels, 3 ng/ml. Decreased red cell folic acid levels, 150 ng/ml. Increased plasma LDH levels. Normal plasma vitamin B12 levels. Pfau, formiminoglutamat, excretion test or histidine load test. Pfau is an intermediate catabolic product of histidine. Folic acid deficiency is associated with increased excretion of Pfau in urine. Pfau excretion is an index of folate deficiency. It is due to impaired conversion of Pfau to glutamate in a reaction requiring THF. Figure 21.23 Role of tetrahydrofolate, THF, and histidine in Pfau test.
Deficiency of folic acid in hyperhomocysteinemia. Folic acid is required for the conversion of homocysteine to methionine. Folic acid deficiency is associated with increased plasma levels of homocysteine. A high level of homocysteine is a risk factor for heart disease. Increased levels of homocysteine in the blood can damage the lining of the arteries. High levels may also make the blood clot more easily. This can increase the risk of blood vessel blockages. Hyperhomocysteinemia is also associated with low levels of vitamins B6, B12, and certain renal disorders. Folic acid supplementation decreases plasma homocysteine levels.
Importance of folic acid during early pregnancy. Closure of the neural tube occurs around the 28th day of pregnancy. The incidence of neural tube defects, spina bifida and anencephaly, is reduced by 400 g folic acid supplement per day before conception and during the first month of pregnancy.
Therapeutic use of folic acid. Therapeutic dose of folic acid is 1 mg per day. It should not be given alone to macrocytic anemia patients. It is commonly given with vitamin B12. 21.15 Vitamin B12, cobalamin.
Vitamin B12 or cobalamin is a water-soluble hematopoietic vitamin only synthesized by microorganisms. It is also known as cyanocobalamin, an anti-pernicious anemia factor and extrinsic factor of Castle.
Structure of vitamin B12. It is a complex tetrapyrrole ring structure called a Corin ring having cobalt in the center. The structure resembles heme with cobalt in a coordination state of 6 with a dimethylbenzimidazole group nitrogen coordinated to one axial position, the 4 equatorial positions coordinated by the nitrogens of the 4 pyrrole groups, and the 6th position is occupied by either a deoxyadenosine group, a methyl group, or a cyanide, CN, group.
Figure 21.24 Structure of vitamin B12.
Sources of vitamin B12: egg, liver, meat, poultry, shellfish, milk, and milk products. Animals get it from their natural bacterial flora or eat other animals that have stores of the vitamin. Vegetarians are at risk of deficiency. Absorption, transport, storage, and excretion of vitamin B12. Dietary cobalamin is released from protein complexes by the action of HCl and enzymes present in the stomach, duodenum, and jejunum. It combines rapidly with a salivary glycoprotein that belongs to the family of cobalamin-binding proteins, known as haptocorin or transcobalamin I or R binder protein. In the small intestine, the haptocorins are hydrolyzed by pancreatic trypsin and the cobalamin binds with intrinsic factor, IF, which is a glycoprotein. IF is secreted by the gastric parietal cells. Vitamin B12 intrinsic factor complex recognizes surface receptors of mucosal cells in the ileum and is absorbed. The IF cobalamin complex passes to the ileum, where IF attaches to specific receptors named cubulin found on the microvillus membrane of the enterocytes. Cubulin with its ligand IF cobalamin complex is endocytosed. The cobalamin IF complex enters the ileal cell where IF is destroyed and cobalamin is set free. Bile, HCO3 and suitable pH are also required for its absorption. Cobalamin is transported around the body bound to specific B12 binding protein transcobalamin, TC. 3 types of transcobalamin participate in the transport of cobalamin. TCI binds 90% of vitamin B12 and may function as a circulating storage form, haptocorin. TCII carries newly absorbed cobalamin to tissues and helps with the uptake of cobalamin receptors on cells for TCII. C8 delivers cobalamin from the periphery back to the liver. It is stored mainly in the liver in amounts, 3 to 5 milligrams, sufficient to last a couple of, 3 to 6, years. Excretion of vitamin B12 mainly occurs through fecal loss, which is 0.1 to 0.2% of total body reserve.
Figure 21.25 Absorption of vitamin B12.
Recommended dietary allowance, RDA, an adequate intake daily, aid*, of vitamin B12. Infants, 0.4-0.5 g. Children, 0.9 to 1.2 g. Men and women, 1.8 to 2.4. Pregnancy, 2.6 g. Lactation, 2.8 g. Functions/biochemical role of vitamin B12. 1. Vitamin B12, as deoxyadenosylcobalamin, is a coenzyme for methylmalonyl-CoA mutase.
Figure 21.26 Role of vitamin B12 as a coenzyme for methylmalonyl-CoA mutase. 2. Vitamin B12 is involved in methionine metabolism. It acts as a coenzyme for methionine synthase. Tetrahydrofolate is converted to N5-methyl tetrahydrofolate in many different reactions as it accepts methyl groups. The methyl group can only be removed and the tetrahydrofolate is regenerated by this reaction. Figure 21.27 Role of vitamin B12 as a coenzyme for methionine synthase.
3. As lipotropic factor, it activates and regulates the overall fat mobilization from fat deposits. Deficiency of vitamin B12. Dietary deficiency is rare, except for vegetarians. Its deficiency is more commonly due to an absorption problem. The autoimmune disease can destroy the parietal cells that secrete the intrinsic factor, IF, required for absorption. Causes of vitamin B12 deficiency. Reduced production of intrinsic factor. Pernicious anemia, most common cause. Gastrectomy, surgical resection. Pancreatic insufficiency. Fish tapeworm infestation, rare. Helicobacter pylori infection. Crohn's disease. Transcobalamin 2 deficiency, rare. Blind loop syndrome.
Effects of vitamin B12 deficiency. Deficiency of vitamin B12 produces hematologic abnormalities such as megaloblastic anemia and neurologic manifestations as subacute combined degeneration of the spinal cord, SCD. Impaired methylmalonyl CoA mutase causes the accumulation of an unusually odd number of carbon fatty acids. These accumulate in nerve cell membranes causing irreversible neurological disorders. Impaired methionine synthesis traps tetrahydrofolate as N5-methyl tetrahydrofolate folate trap. This can lead to a secondary or artificial deficiency of folic acid. One of the main symptoms of folic acid deficiency is anemia. Anemia due to a true folic acid deficiency is megaloblastic anemia. Anemia due to a true secondary folic acid deficiency caused by primary B12 deficiency is pernicious anemia.
Neurological changes in vitamin B12 deficiency. Initial complaints of paresthesia due to peripheral nerve involvement. Next, complain of difficulty in maintaining balance as a result of posterior column involvement. The cerebral function may be altered in more severe cases. Sometimes dementia and other neuropsychiatric changes may precede hematologic changes. Vibration and position sense are lost and the gait becomes ataxic at a later stage. Megaloblastic anemia, it is the most important symptomatic feature of vitamin B12 deficiency, characterized by low hematocrit, 10 to 15%, and may be accompanied by leukopenia and thrombocytopenia. It is also associated with changes in mucosal cells, leading to glossitis, as well as other nonspecific gastrointestinal disturbances such as anorexia and diarrhea. Physically, patients look pale and slightly icteric. The blood film shows macrocytic red cells and a hypersegmented neutrophil. Laboratory diagnosis. Elevation of MCV, 110 and 140 FL. Abnormally large erythroid cell size and asynchronous maturation of the nucleus and cytoplasm, i.e., cytoplasmic enlargement but retarded nuclear development. Giant metamyelocytes are characteristically seen. Elevation of serum lactate dehydrogenase, LDH. A moderate increase in indirect bilirubin. Low vitamin B12 serum level, normal is greater than 240 pg/ml. Megaloblastic anemia due to folic acid deficiency has low folate in RBCs, while vitamin B12 levels are normal. As vitamin B12 deficiency affects all hematopoietic cell lines, in severe cases the white blood cell count and the platelet count are reduced and pancytopenia is seen. Elevation of serum level of methylmalonic acid, greater than 1000 nmol/L, normal is up to 400 nmol/L. Schilling test indicates poor absorption of vitamin B12, but this test is no more in use now.
Pernicious anemia. It is a chronic illness caused by impaired absorption of vitamin B12 secondary to autoimmune destruction of intrinsic factor, if, in gastric secretion. The disease was so named pernicious anemia because it was fatal before treatment became available. It is also known as Addisonian anemia. The term pernicious is no longer suitable, but it is reserved for historical reasons. It is characterized by decrease in the number of RBCs. Increase in the average size of RBCs. Nucleated RBCs of blood. Decreased concentration of hemoglobin. Increased level of bilirubin. Bone marrow hyperplasia. Demyelination of white fibers of the spinal cord.
Urinary retention and impaired micturition may occur because of spinal cord damage. Half of the patients show a smooth but painful beefy red tongue with loss of papillae. Various gastrointestinal symptoms include anorexia, nausea, vomiting, heartburn and flatulence. Absolute achlorhydria. Treatment is lifelong injections of vitamin B12 as oral administration is not much useful. Cobalamin deficiency is hypothesized to lead to a deficiency of the tetrahydrofolate forms needed in purine and thymidine monophosphate synthesis, resulting in symptoms of megaloblastic anemia. Intramuscular injections of 100 g of vitamin B12 are adequate for each dose. It is usually given daily for the first week, weekly for the first month, and then monthly for the whole life. An oral dose of 1000 g/day can also be effective but must be continued indefinitely. Other uses of vitamin B12. 1. As an antidote for cyanide poisoning, hydroxycobalamin is used as an antidote to cyanide poisoning. It works by helping cells in the body by converting cyanide to a form that can be removed from the body through urine. 2. It regulates the excessive production of the allergen antibody IgE in allergic persons. 3. Control of depression. Vitamin B12 enhances the production of serotonin to reduce the incidence of depression. It is quite helpful to elderly persons, whose production of serotonin is usually low. 4. Homocysteine control. It is used to prevent the elevation of homocysteine levels by regulating methionine metabolism. 21.16 Some vitamin-like substances. Some compounds are not true vitamins but have a definite role in body metabolism. 1. Choline. Choline is a trimethyl derivative of hydroxylethanelamine, betaine. Its animal sources are liver, milk, and eggs, while plant sources include cereals and vegetables. It is synthesized from serine or betaine. It performs the following important functions. Choline is important in nervous transmission as acetylcholine and as a store of label methyl groups. Choline as a lipotropic factor, it prevents the formation of fatty liver. It is required for the formation of phospholipids and then lipoproteins. Phosphatidylcholine is present in the membrane structure. It is actively involved in 1-carbon metabolism, because of the presence of 3 methyl groups. Since phosphatidylcholine might increase acetylcholine, there is interest in using it for improving memory and for conditions such as Alzheimer's disease. 2. Lipoic acid. It is a sulfur-containing fatty acid. Its chemical name is 6,8-dithiol-octanoic acid. Its oxidized form is lipoic acid and its reduced form is dihydrolipoic acid. It acts as a cofactor for enzymes of redox reactions. It is used to suppress oxidative stress by decreasing the production of reactive oxygen species, ROS, and increasing the formation of glutathione. It is also useful in the prevention of stroke and myocardial infarction as it reduces insulin resistance and decreases plasma LDL levels. 3. Inositol. Inositol is hexahydroxycyclohexane sugar alcohol, also known as myo-inositol or meso-inositol. It is present in fruits, vegetables, whole grains, yeast, muscle, the brain, erythrocytes, and in the retina. Phosphatidylinositol 4,5-bisphosphate is an important constituent of cell membrane phospholipids involved in metabolic processes. Upon stimulation by a suitable hormone agonist, phosphatidylinositol 4,5-bisphosphate is cleaved into diacylglycerol and inositol trisphosphate, both of which act as second messengers for a variety of signaling pathways. In most plasmalogens the nitrogen base is ethanolamine. But in some instances, inositol may be substituted for ethanolamine. It acts as a lipotropic factor along with choline and prevents the accumulation of fat in the liver. 4. Para-aminobenzoic acid, PABA. It is the structural constituent of folic acid. It is synthesized by the bacteria and is essential for their growth. The sulfanilamide drug is structurally similar to p-aminobenzoic acid and inhibits the enzyme, dihydroaptate synthetase, responsible for incorporating p-aminobenzoic acid into folic acid. Sulfanilamide competes with PABA and acts as a bacteriostatic agent. 5. Vitamin P. It is a group of plant compounds called flavonoids. They are found in deeply colored fruits, vegetables, cocoa, tea, and wine. Rutin, citrin, esculin are examples of vitamin P. Vitamin P obtained its name due to its ability to decrease membrane permeability. They act as antioxidants and may help protect against chronic diseases. 6. Carnitine. Carnitine is a beta-hydroxy-gamma-trimethylammonium butyrate. It is mainly obtained from animal-based foods. It is also synthesized endogenously. It is involved in the transport of fatty acyl CoA through the inner mitochondrial membrane. Carnitine deficiency is seen in newborn and preterm babies due to inadequate synthesis or renal loss. Summary. Vitamins are several chemically unrelated families of organic substances that cannot be synthesized by humans and are essential in small amounts for normal metabolism. A deficiency of a vitamin in the diet leads to a health problem.
Vitamins are divided into two groups: fat-soluble, vitamins A, D, E and K, and water-soluble, vitamin B complex and vitamin C.
Vitamin A supports healthy skin and mucous membranes of the gastrointestinal, urinary, and respiratory tracts. Promotes vision and immunity. Helps with bone and tooth growth. The early sign of vitamin A deficiency is a loss of sensitivity to green light. Prolonged deficiency causes impairment to adapt to dim light, and more prolonged deficiency leads to night blindness. Vitamin D is a fat-soluble vitamin also known as cholecalciferol, ergocalciferol and anti-rickety factor. The importance of sunlight exposure is quite significant in the formation and activation of vitamin D. The final active form of vitamin D is 1,25-dihydroxyvitamin D, which is produced in the kidney by the enzyme 1-alpha-hydroxylase. Vitamin D promotes the absorption of calcium from the gut by increasing the synthesis of calcium-binding protein in the intestinal mucosa. Vitamin D helps in normal bone and teeth formation. Rickets is the condition of deficiency of vitamin D that occurs in growing children. Osteomalacia is the adult's rickets. Vitamin E is a fat-soluble vitamin also known as tocopherol, antioxidant factor, or anti-sterility factor. Vitamin E acts as an antioxidant. It prevents the formation of peroxides. Protects the vitamin A and polyunsaturated fatty acids from destruction. Vitamin K is a fat-soluble and heat-stable vitamin also known as an anti-hemorrhagic factor or coagulation factor. Chemically, three forms of vitamin K are found. K1 equals plant origin, phylloquinone or phytonadione, isolated from alfalfa plant. K2 equals bacterial origin, menaquinone. K3 equals synthetic, menadione, is more potent than K1 and K2. Vitamin K significantly helps the formation of several clotting factors. Vitamin K is regarded as an essential component of the respiratory mechanism in animals and a photosynthetic mechanism in plants. The main clinical features due to deficiency of vitamin K are deficiency of physiologically active prothrombin, prolonged prothrombin time, abnormal clotting factors, and various hemorrhagic problems. Vitamin C is a water-soluble vitamin also known as ascorbic acid. Vitamin C is required for the activities of fibroblast, osteoclast, and the formation of collagen fibers and mucopolysaccharides of connective tissue. The deficiency of vitamin C results in a disease called scurvy, characterized by swollen and purplish gums with a bad smell, and necrotic changes with bleeding tendencies. Vitamin B1 is a water-soluble vitamin also known as thiamine, anurine, anti-beriberi factor, or antineuritic factor. Thiamine has a key role in energy-yielding reactions and the metabolism of carbohydrates. Most of its functions are carried out after being converted to thiamine pyrophosphate. Beriberi is a deficiency of thiamine characterized by severe weakness and a state of paralysis. Riboflavin or vitamin B2 is a member of the vitamin B complex family and is also a water-soluble vitamin. The most important biologically active forms of vitamin B2 are flavin adenine dinucleotide, FAD, and flavin mononucleotide, FMN. They participate in a range of redox reactions. Niacin or vitamin B3 is a member of the vitamin B complex family and is also a water-soluble vitamin. Niacin is part of two very important coenzymes, nicotinamide adenine dinucleotide, NAD+, and nicotinamide adenine dinucleotide phosphate, NADP+. Pellagra is the deficiency of niacin. It is commonly referred to as 3DS as dermatitis, dementia, diarrhea, and 4th-D for death if not treated properly. Vitamin B5 or pantothenic acid is another member of the vitamin B complex. It is an essential part of coenzyme A. Vitamin B6 is a water-soluble and heat-stable vitamin. It consists of 3 closely related compounds, i.e., pyridoxine, alcohol, pyridoxal, aldehyde, and pyridoxamine, amine. Pyridoxal phosphate, PLP, pyridoxal 5-phosphate, P5P, is the active form of vitamin B6. Biotin is a water-soluble B-complex vitamin formerly known as anti-egg white injury factor or vitamin H. It mainly participates in carboxylation reactions. Folic acid is one of the members of the vitamin B complex. It is a slightly water-soluble hematopoietic vitamin also known as pteroylglutamic acid, PGA, tetrahydrofolate, THF, or vitamin B9.
Folic acid acts as a coenzyme in many reactions involving the transfer of one carbon atoms to other compounds. Vitamin B12 or cobalamin is a water-soluble hematopoietic vitamin only synthesized by microorganisms. Vitamin B12 is involved in methionine metabolism. It acts as a coenzyme for methionine synthase. A deficiency of vitamin B12 produces hematologic abnormalities such as megaloblastic anemia and neurologic manifestations as subacute combined degeneration of the spinal cord, SCD. Pernicious anemia is a chronic illness caused by impaired absorption of vitamin B12 secondary to autoimmune destruction of intrinsic factor, IF, in gastric secretion.
References. Exercise questions. MCQ 1. A group of biochemists was conducting a research experiment to investigate the role of vitamin A in vision in the retina of certain animals. They observed that all-trans-retinol is not converted to 11-cis-retinol due to the effect of an experimentally used inhibitor. Which of the following biochemical reaction is blocked by the inhibitor in this experiment? Dehydrogenation, hydrolysis, isomerization, oxidation, reduction. MCQ 2. A 10-year-old girl is brought to the hospital for complaints of dry eyes due to scanty tears with blinking difficulty, generalized weakness, growth retardation, and other dry body surfaces. She was looking malnourished. Detailed history and relevant laboratory investigations revealed that she is suffering from vitamin A deficiency. Which of the following proteins is deficient in her tears? Albumin, glycoprotein, phosphoprotein, prealbumin, sulfoprotein. MCQ 3. A group of biochemists conducted a research experiment to investigate the role of vitamin A in vision in certain animals. They observed hydrolysis of photorhodopsin into opsin and vitamin A under normal conditions. Which of the following forms of vitamin A is produced in the above experiment? 11-cis-retinaldehyde, 11-cis-retinol, 11-trans-retinol, all-trans-retinaldehyde, all-trans-retinol. MCQ 4. Which of the following disorders occurs in vitamin D deficiency? Kidney failure and bent bones, megaloblastic anemia and Wernicke-Korsakoff syndrome, osteomalacia and xerophthalmia, osteoporosis and diverticulosis, rickets and osteomalacia. MCQ 5. Which of the following amino acid modifications requires the activity of vitamin K related to the blood coagulation cascade? Aspartate to carboxyaspartate, glutamate to gamma-carboxyglutamate, lysine to methyllysine, lysine to hydroxylysine, proline to hydroxyproline. MCQ 6. A 62-year-old chronic smoker and alcoholic man presented with odynophagia, insomnia, epigastric discomfort, and recurrent diarrhea. Clinical examination revealed memory disorientation, stomatitis, glossitis, esophagitis and exfoliative dermatitis with some vesicles on erythematous bases on exposed parts of the body. Which of the following vitamins is deficient in this patient? Biotin, cobalamin, niacin, riboflavin, thiamine. MCQ 7. A 10-year-old girl is admitted to the hospital with ketoacidosis. Lab reports revealed severe disturbance in glucose metabolism. Which of the following vitamins is deficient in this patient? Vitamin B1, Vitamin B2, Vitamin B3, Vitamin B6, Vitamin B12. MCQ 8. A 15-year-old girl consulted a doctor for complaints of skin dryness, hyperemia, edema of the mouth and throat, angular stomatitis with swollen and cracked lips. She also gave a history of hair loss for the last few months. Which of the following vitamins is deficient in this patient? Vitamin B1, Vitamin B2, Vitamin B3, Vitamin B6, Vitamin B12. MCQ 9. A 58-year-old woman presented with complaints of swollen and painful bleeding gums. History revealed that her diet is restricted and includes no fresh citrus fruits or leafy green vegetables. Which of the following vitamins is most likely to be deficient in this patient? A. B1, B2, C, D. MCQ 10. Lipoic acid is not considered a true vitamin, but it is an essential cofactor for several important enzymes. Which of the following consequences occurs in the deficiency of this vitamin? Decreased insulin sensitivity, decreased production of reactive oxygen species, increased energy generation from carbohydrates, increased hepatic production of triglycerides, loss of the ability to clot blood. End of Part 4 of 4 of Chapter 21. Thank you.